I'm really honored to be part of this group, and I'm going to step down here because I also wanted to point out to some of the slides and really thrilled about the possibility to share a little bit on how we can image the heart and hopefully prevent stents from happening, preventing heart attacks. A lot that you have heard here from what Dr. Miedema has mentioned is, how we can prevent, plaques from growing and hopefully regressing with appropriate lifestyle medications, and how we're going to treat if we need to treat. My job as an imager is, and that was my assignment, non-invasive coronary artery imaging. Let's break it down. What are we talking about non-invasive? So on the left side here, we have a non-invasive test that we're going to be talking about, which is a CAT scan that will produce those images that you just heard from Dr. Miedema. And on the right side is actually when we define the problem, we identify the problem, we can fix that. That would be the invasive. And nowadays, we can actually identify and detect who has risk using a non-invasive test. We don't need to use coronary angiography to detect that disease. I think if we take one slide from home tonight, would be this slide. We have been talking all along about this, but I think this demonstrates what exactly happens as we age. As we are in this country, it can be anywhere, and in some countries that gets accelerated by lifestyle that you heard. But I think, this is important to put as a framework. And I have to declare here that I'm still in a sentence that we were discussing before from Dr. Miedema. Put it simply, the biggest plaque, the plaque that is the ugliest, perhaps might not be the one that is going to cause you to have the heart attack. Most of the heart attacks, as you have heard, occur in folks that do not have plaques. They are super narrow. They're super tight. Most of the heart attacks occur in these lumps and bumps. Plaques that are somewhat soft, that will probably not have a lot of calcium. Actually, calcium is something that we perhaps would like to have to a certain extent because it is already a process that has quieted down. But wherever they see calcium, there might be plaques that might still at risk for rupture. The calcium tells you, okay, I've been there, leave me alone. There's a scar that has created. But obviously it denotates a risk because wherever you see scar, there might be some other areas that are still in this process of fighting. And that's why medications are so important. What does this slide shows us here? It shows us that, when you have been sent for, you have heard anecdotes, right? You have heard of folks that said, I had a stress test that was completely normal, and then a couple days later, a couple months later, I had a heart attack. And the stress test was completely normal. When we're looking at the stress test, we're looking at the very far end of the spectrum. We're looking at those plaques that are quite tight, and hopefully tight enough to cause the problem that Dr. Miedema had just shown. A nuclear stress test that was positive. A treadmill test that would be positive. But actually, those plaques, although they can rupture, they can cause heart attacks. Most of the heart attacks actually occur in these vulnerable plaques. These are plaques that are not tight enough yet to produce symptoms, but they're there, and they can sometimes rupture a little bit, and the body tries to heal. And sometimes some of these plaques get calcium built up and says, okay, we're done. So how can we detect this process a little bit earlier? Because if we're going to detect just on the far end, yes, we'll be picking up folks that have symptoms, but our job is to hopefully identify those that would be at risk, those that would be vulnerable. So this is on the Time magazine a few years back. Now we have a test that we can identify where the plaque is and what the problem is. Have you ever had, who has heard about coronary calcium scoring? Actually, it's interesting that there's all this group was just here. I mean, it's almost like there's a separation, geographical separation. The calcium scoring, huh? So this group has heard. I'm going to probably focus here more on this group that hasn't heard. But if you have a test to pick, just rewind here for a second. Risk factors are important. There's no doubt that cholesterol, lifestyle, smoking, diabetes control, blood pressure control are extremely important and multifactorial. But if you wanted to see what is one individual risk, you need to look at the heart. Risk factors are important to define the risk on a general population. If you have somebody that is diabetic, that has this, and that, your risk is likely to be Y. But what is my own risk, my personal risk? I can tell that by the CAT scan. And the CAT scan actually can measure how much calcium there is. The more calcium you have, the more likely you probably could have an event, and we can intervene on that. And having talked to some patients and said, that's the best investment I made. It's $99, you get that, get your heart scanned. And if you have a heart scan, then you can potentially change the course of that disease and hopefully punt this heart attack, God forbid, for never happening. And this might change your lifestyle. And we talk a lot about doing screening for prostate cancer, right? We talk a lot about doing screening for breast cancer, but we never talk about screening for heart disease. We screen for risk factors, but we don't screen for heart disease. Just look at the arteries, and the arteries will tell where you are. This is a study showing that when you look at the traditional risk factors and you divide the population into low risk, intermediate, and high risk, you can see that despite being high risk by all the risk factors, if you do not have a lot of calcium, which is this hashed one here, you actually have a very low risk. Despite being labeled as high risk, if you don't have a lot of calcium, you're actually fine. So actually what defines the risk, in addition to the risk factors, is also how much plaque buildup you have. And this is another study, very interesting. Here's this, what they call, calling the power of zero. If you do a heart scan and your calcium score is 0, go celebrate. I mean, obviously, don't use that if you're having symptoms. You should take that, you got to pay attention to that. But as a method of screening, should I be on a cholesterol or not, that is sometimes quite important. Because despite, again, being high risk or considered for a statin, you can look at this group here in the middle. Actually, 57% of them have a 0 calcium score. This is another important work that has been published recently, a large cohort that's showing that if you have a calcium of 0, let's just look at the red curves. That's time in the x-axis, and in the y-axis is mortality, events. So in red, who is in red? The calcium is 0, they were taking statin. They were taking cholesterol medications. On the dashed red line is they have calcium of 0 and they were taking no statin. So if you have 0 calcium, it does not matter whether you take or not. Taking cholesterol does not make a difference in terms of your risk. Versus if you have a calcium above 100, it would make a difference to take the cholesterol. So we should not put cholesterol to everybody, but cholesterol should be applicable to who has disease. And now we can tell who has disease or not. This is actually a work by Dr. Miedema, looking at a big cohort of patients, amazing study, and looking at several cohorts of patients. Okay, you're telling me that based on the risk factors, I should be taking cholesterol. Guess what? More than almost 50% of these patients have a calcium of 0. So, sometimes you might not derive the full benefit. Obviously, just looking at the calcium is one story. There is obviously non-calcified plaque, which you would not be able to see it with the traditional calcium score. That's the example that Dr. Miedema has shown, and I'll take it to you. I'll mention to you. So this is the new updated guidelines, and they're talking about cholesterol medications. If you have an adult, 40 to 75 without diabetes, and you have a cholesterol between, a bad cholesterol between 70 to 190, and your risk is intermediate, you should consider looking at the calcium score. See how much calcium you have. Sometimes patients are reluctant to take statins, and rightfully so. Show me why. Tell me why do I need to take that. My cholesterol is somewhat borderline. Do I need to look into the calcium? And that's the opportunity that you could have. And it's incredible how things can come in different shapes. Now it's switching gears to another type of CAT scan, but this one now involves contrast. You can see that by the pictures that now we have some brightening on the arteries. And you can see 2 types of disease. On the left side, you have a 78-year-old male that has angina, that has chest pain when she exerts herself, and she has heavily calcified. There's a lot of calcium built up, and some of these vessels, because of the narrowing of the calcium, now have become tightening and is creating her chest pain. On the other side, you have a 42-year-old male with chest pain when he exerts himself, has a strong family history, and guess what? He has no calcium, but he has a dark plaque. These dark plaques, the calcium is going to be 0. And why is that? Why the calcium will be 0 despite having plaques? It is because it takes time for these plaques to be healed over time and calcified. So the calcium scoring for somebody that is young, it might not be a good one because Their calcium scoring might be 0, and yet they could have risks. So if you have symptoms, calcium scoring, in my view, is not a good test. Calcium scoring is a good test to decide who should be on cholesterol or not. If you're having symptoms, perhaps that CAT scan might be the best test because it will tell you not only how much calcium you have, but how much soft plaque you have. And the CAT scans have also gotten so much better now that they allow us to see very beautifully the vessel and very similar to what Dr. Burke, Dr. Berlakis, Dr. Santiago Garcia also do in the cath lab. It's fixing these vessels once there is an narrowing. And with that, I'd like to conclude that know your numbers. Know your weight, obviously your blood pressure, know your cholesterol, and perhaps even know your calcium scoring. And medications hopefully should be tailored to those that have the disease. And the best way, I guess, to look at the disease process is to look at the vessels, look at the disease. And we're trying to balance, cost effectiveness here. Once we know the disease, then we can intervene not only in the risk factors, but then throughout the course of that and hopefully prevent heart attacks and prevent other stents. Thank you very much. Great.